Hello, I'm Allan Kellehear. I'm a clinical professor in the College of Nursing and Health Sciences and the Robert Lana College of Medicine at the University of Vermont in the USA. And I'm here today to speak to you for 15 minutes or so on compassionate communities, the concept and practice around the world. So we have to start with how we currently think about palliative care, and we have to think about resetting that idea. And the reason why we need to reset the idea into a greater public health framework is really three major reasons. One is what I call the 95% rule. The 95% rule basically suggests that people who live with life-limiting illnesses, people who care for them, and people who live with grief and bereavement spend less than 5% of their time in front of a doctor or a nurse. 95% of the time, they're alone, or with family, or with friends, or with their workmates, or with their animal companions, or with their stereo system, or with the internet, or their animal companions. So if we're serious about end-of-life care, we have to ask ourselves, what are we doing in that 95%? That 95% of the time where people are not in front of a clinical service, not in front of their health service, because that is where the action is. The second major reason we have to think about reimagining palliative care in public health terms is to remember the social epidemiology of dying, caregiving, grief, and loss. We tend to forget that dying or living with a life-limiting illness, or living with long-term caregiving, or living with grief and bereavement has its own morbidity and mortality, premature death. It's the anxieties that people live with, the depression, the social isolation, the loneliness, the job loss, the lost school days, the lost income, social rejection, the stigma, and worse, premature deaths, the sudden deaths, the suicides. All of these morbidities, premature mortality, are amenable to prevention. And if we can't prevent them, we can harm minimize, harm reduction. We can act early intervention. The social epidemiology of dying, caregiving, and grief and loss, these experiences that accompany those journeys, the negative experiences that accompany those journeys are amenable to prevention, harm reduction, and early intervention. They are issues that can be and must be tackled beyond the clinic, beyond the direct clinician-patient relationship. They have to be tackled in the 95% area of people's lives when they are not in touch with a health service. And finally, palliative care has historically been concerned with comfort care, with symptom science. We are, to some extent, acute care people. We are people who institutionally care for people. Even when we care for people at home, our concerns are primarily around pain and suffering, breathlessness, cachexia, all of these kinds of things. We see dying and we often see caregiving and bereavement in terms of problems, challenges that we need to address and that we can solve or ameliorate. But actually, there's more to dying and grief and caregiving than troubles. We often forget that despite how difficult and dark some of these journeys can be for many people, there are aspects of health and well-being that need promotion and that need to get a better grip and a greater balance in people's lives during this time. Studies have shown that despite the rise of stigma and social rejection in many people's lives, there is also new friendships and a growing intimacy, especially between partners. That it is a time of reflection and reminiscence. That it's not just a time of fear, but it's also a time of courage, a time of transcendence, of meaning-making, of creating stories about one's life, about saying goodbye, and about preparing, and about working out how to negotiate new relationships into the future. All of these things are positive things. And if we're interested in balancing and tackling the morbidities associated with dying and caregiving and grief, then we need to tackle and promote the health and well-being aspects of this journey that we often overlook in our haste and our well-intentioned haste to address the suffering of those in this journey. These are the three great reasons for a public health approach within palliative care that takes us beyond our clinical work, yet complements it and strengthens it. Compassionate communities are the cornerstone of a public health approach to palliative care. We're not talking about epidemiology here or health services research or bench science. We're talking about community development, community engagement, civic participation. Every civic sector must contribute and do their bit, just like they do in health. Health is not about going to the doctor. We know that. That's not an idea that's been popular since the 60s. Everybody does their bit to maintain their health and to keep their health and well-being. Workplaces have legislation that guides the protection and safety and care of their workers. You know you're supposed to eat well and exercise. You're supposed to wear your seatbelt and your condom and your bicycle helmet. And these are all modern public health ways in which every individual takes responsibility for their health. And so it is for death, dying, caregiving, and living with loss. Everybody has a responsibility. Every school, every workplace, every faith group, every neighborhood, every cultural center, every educational resource, every club, every art gallery, every museum has a role to play in providing supports for people who are living with life-limiting illnesses, have caregiving responsibilities, and live with loss. They can play a policy role in terms of increasing support for people in their sector who are living with these experiences. And they also can provide educational opportunities, provide resources and information for the people who pass through their particular civic sector. This is where health services and civic action become true partners, where continuity and quality of care are genuinely addressed. If you're interested in continuity of care, we must form a partnership with the civic sector. This is not about a handover between the healthcare sector and the social care sector. This is about a handover between professionalized care and the community itself, civic society. It's not about generating volunteers. It's about getting schools on side, helping them to realize how they can play an active and practical role in caregiving. And this means then that palliative care is not about specialists or primary care. Palliative care is everybody's responsibility. Absolutely everybody has a role to play in real time and in real practice. Because palliative care is everybody's business, we use half a dozen well-known public health practice methodologies, community development and neighborhoods, really. We call them compassionate communities here, but they're essentially neighborhoods that come together to look after each other. The neighbors actually look out for the elderly, for people living with life-limiting illnesses, people supporting people with caregiving responsibilities, and also recognizing and supporting people living with loss. That's what community development is. These can happen in neighborhoods and small villages, but they can also be compassionate communities in workplaces. There's no reason why banks and their employees can't create compassionate communities for the employees who are journeying through these experiences whilst being employed, or schools for that matter. Compassionate cities are a larger scale form of compassionate community. Many compassionate cities use what we call the Compassionate City Charter, which is a 12-point charter guiding the local town hall, the mayor's office, into promoting and encouraging schools and workplaces, businesses, if you like, and the faith groups, clubs, cultural centres, to take a public education role and supportive role for people in this area. Public education, end-of-life literacy, like health literacy, terribly important. It can be done by all sectors. It doesn't necessarily have to be done by professionals. And the idea that we promote health and well-being inside experiences of living with a life-limiting illness, inside experiences of caregiving and living with loss and grief. This is not all a dark story. There are health and well-being aspects, and people need to know what those aspects are and how best to promote them. That's health promotion, and that's where public education also plays an important role. Civic policy development is also a key to this. Schools need to develop their own policies. They don't necessarily have to put death, dying, and end-of-life care in their curriculums, but they must have a policy on the ground, in the playground, and in the classroom for students and teachers and administrative people who are experiencing serious illness or health crises and grief and loss as they work and study. Partnerships between us as leaders in palliative care, professional palliative care, and the civic community are essential for this to work. So the global developments for this particular approach to palliative care, we've had a number of major cities adopt the Compassionate City Charter and try to encourage their schools and workplaces and businesses and their cultural centres to adopt a compassionate care approach to palliative care, to play an active and practical role in supporting their palliative care services. Wales, for example, has a compassionate communities policy. There's a population of 3 million. Ottawa in Canada, there are several compassionate communities across there as well. Montreal has 2 compassionate community programs as we speak. Plymouth in England is, I think, one of the first compassionate cities. Birmingham, England has just come on board, and they are working as a compassionate city, bringing all the civic sectors under one umbrella to look at the issue of end-of-life care and what they can do to contribute to that. Inverclyde in Scotland, Vic and Seville in Spain. These are all cities that have engaged with this. New Westminster, Vancouver in Canada. Coshicode, a very famous example, one of the longest examples of a compassionate city and compassionate community. They've been doing it for many years now, over 20 years or so. Cologne in Germany has just started their program. Mankato in Minnesota, USA. Taipei, a very large Chinese city in Taiwan. Bern, the capital of Switzerland, has a compassionate city led by the palliative care program that comes out of there. So wonderful things. There are hundreds of compassionate communities, which are communities, neighbourhood communities, village communities. In Shropshire in England, there are at least 70 compassionate communities. There was a recent report done showing that there are hundreds of compassionate communities and villages across the United Kingdom. The same is true also now of South America and Canada. Taiwan has at least 20 compassionate communities, aside from the fact that Taipei is a compassionate city. So these developments are spreading and they're becoming very acceptable. Many people see these as an extension of the WHO Healthy Cities movement, but we call them compassionate communities or compassionate cities because they integrate death, dying, and end-of-life care into the broader idea of the public health and well-being. These are our professional developments. For those of you unfamiliar with it, there is now an international association membership organization where you can join. There's a biennial international public health palliative care conference. One has just finished in Belgium, attracted 350 people or so. Compassionate Communities UK, a registered charity. We have a SAGE, Palliative Care and Social Practice Journal devoted to public health ideas and palliative care. The European Association for Palliative Care has a public health reference group now. Public Health England and Palliative Canada distribute toolkits for how to do this kind of work. The Scottish Public Health Network, Scottish Partnership, have been very active in policy right across Scotland. England's done the same with their ambitions policy, and we've just seen the latest Oxford textbook on public health and palliative care. Which brings me to the final point, which is that Sigmund Freud, who was not really known for his sense of humor, once told a joke that a man who wrote to his wife said, "Darling, if one of us should die before the other, I think I shall move to Paris." That's a great story because it's a story that says that no one thinks that dying is going to happen to them. It's always the other one, the other guy, the wife, not the husband who wrote the letter. Death, dying, and end-of-life care affects us all. It cannot confine itself to a clinical service. Palliative care cannot stop at being a clinical service. It must become a public health speciality as well. Public health, compassionate communities, compassionate cities. This is the future of end-of-life care. Thank you very much.